good to go.
Good afternoon, everyone who's joined us online. We'll start in a few minutes. If you bear with us, we'll just wait for a few more people to join. Thank you.
Okay, I'm in the meeting now, Danny. Give me, I'll organise it.
Okay. Thank you everyone for joining our Wellington Hospital Lunch and Learn. I'd love to introduce you to Dr. Dipa Jayaseelan, a consultant neurologist. I'll let you introduce yourself, Dipa.
Thanks, Holly. So hi, I'm Dipa Jayaseelan. I'm one of the neurology consultants here at HCA. I'm really sorry this is online. It was meant to be in person, but we got our dates all mixed up. But hopefully we'll try and keep this a little bit interactive. So please just stick up your hand and talk to me and ask me questions as I go along. Please feel free to interrupt. Let me just tell you a bit about me. So I am a consultant neurologist based between the National Hospital for Neurology and Neurosurgery at Queen Square and West Hertfordshire Hospital NHS Trust. So for all of you who send any patients or have any patients from Watford General, I will often see them there. From a HCA point of view, I have a regular clinic at Elstree. I'm also at the Platinum Medical Centre at Wellington and the Physicians Clinic. So practicing across a number of places. So my specialty is in, just hold on one second.
You want to know which part of this?
I'm in a meeting.
You've been waiting.
I'll have to do it after. So my specialty is in neuromuscular disorders. And so I thought I'd talk to you a little bit about neuromuscular disorders in general practice and what kind of things you commonly see, when you should be referring, what kinds of things you can do while you're waiting to refer, and what things may be the worrying signs that might want you to make you want to refer to someone like me. So I'll get started if that's all right. So we're just going to talk about common neuromuscular presentations, red flags that need urgent referral, key first-line investigations, and to know when and how quickly to refer to neurology. So what are the most common neuromuscular presentations that you'll see in general practice? Well, I think weakness is probably the number one thing on there, alongside with numbness and neuropathic type symptoms. So that's burning or shooting, fatigue, muscle twitches. Those are kind of the things that end up in my neuromuscular clinic more than anything else. And then what things will make you think of a neuromuscular cause? So this is the only anatomical looking bit of the presentation I'm going to stick on there. So essentially, when we think as neurologists, when we think about neurology, we think about the upper motor neuron and the lower motor neuron, the upper motor neuron being the bit of the brain and the spinal cord, and the lower motor neuron being everything else, basically. And so when we think about neuromuscular conditions, we're thinking about the lower motor neuron and the everything else. So what is the everything else? Well, we talk about the nerve root, so radiculopathies, we talk about plexus problems, we talk about the peripheral nerve itself, and then the neuromuscular junction, the muscle itself, and then of course your anterior horn cell, which is what you get affected in motor neuron disease. But as I said, that's the only bit of anatomy I'm going to show you for the whole of the rest of the talk, and the rest is going to be all very clinical. So when do I think about a neuromuscular cause? Well, when I'm seeing patients in clinic, the things that make me think, oh, this is neuromuscular rather than maybe a stroke or something more central in the nervous system, things like proximal bilateral weakness, distal bilateral numbness or weakness, and then respiratory and swallowing difficulties. So when patients are having muscle symptoms that are not just in their arms and legs, but also having respiratory difficulties and swallowing difficulties, we're thinking about whether this could be a neuromuscular cause for their problem. And then obviously, as I said just now, when we were talking about the anatomy of it, when they have the lower motor neuron sign, so that's really what's going to point you in clinic to something that is neuromuscular rather than something else. So is there wasting? Is there low tone, hypotonia? Is there reduced reflexes? Those are the kinds of things that are going to point you in the direction of a lower motor neuron neuromuscular cause. So to start with, I thought we'd talk about and think about some cases about patients who present with weakness. So what are the key things you'd want to know when a patient presents with weakness? Well, I guess where the weakness is, that's obviously going to point you in one direction or another. Is it focal? Is it bilateral? Is it symmetrical? When did it start? Does it fluctuate? Is there any numbness or pain? And are there any bladder or bowel symptoms? And I guess those are the key things when a patient presents with weakness. Those are the things that you're going to want to know to help you differentiate between where something is coming from. So the first thing we talk about is it true weakness? And I'm sure a lot of you will identify with this, where the question is there really weakness, or is it something else they're complaining of and they're calling it weakness? So true weakness is reduced power. So when you examine them, you feel the power is reduced, but also when you get them to push, you cannot get it up to the same level, because sometimes patients will have give way weakness where actually the power itself is not so reduced, but they don't feel as strong as they should, but they can get it up to normal power. So that's the first thing. Is there actually fatigue rather than weakness? They're generally just tired and actually don't have the same endurance that they used to. And I guess the biggest one for me is it actually just pain that's limiting the movement? So is it the pain that's stopping them from functioning rather than actually true weakness? Because when you're in a lot of pain, you will feel like something is weak, but actually it's pain that's limiting you. And then some patients will describe weakness, but actually mean numbness. So is it actually that they can't feel that limb or that part of their body and not truly weak? And are there any associated functional symptoms? So when I say that, I mean, are they not able to do up buttons? Are they not able to walk in the same way as before? Can they not use a knife and fork properly? Those kinds of things. And understanding whether you've definitely got true weakness changes the whole differential, because when you have true weakness, you are very worried about a neurological cause and you're worried about progression. Whereas if it's mainly pain, then actually maybe you're thinking about a musculoskeletal cause rather than a neuromuscular cause. So it's important to make that differentiation. And then we talked about pattern of weakness. So pattern of weakness is really important in deciding whether something could be neuromuscular or where in the neuroaxis it is coming from. So if it's proximal and bilateral, you're much more likely to think of a neuromuscular condition. I guess the other big differential is going to be something in the spinal cord if it's bilateral. If it's distal, both hands and feet, you're thinking much more about nerve problems because they tend to start much more distally. Is it focal, unilateral versus bilateral? So is it just one arm? Is it just one hand? And whether it's symmetrical or asymmetrical, and whether it's changing. Is it getting worse as time goes on? Is it worse at the end of the day compared to the beginning of the day? Is there a big fluctuation in symptoms? And then the other thing is the time course. So time course is often a big clue mainly to your red flags, to when you should be worried about things. So is it an acute problem that's coming on over hours to days where you're going to send them probably to A&E straight away? Is it subacute? Has it happened over 6 to 8 weeks? Or has it been chronic and going on for many, many months to years? And obviously anything that involves rapid progression in neurology is usually a red flag, and you're going to send these patients often to A&E. So what if a patient presents with focal weakness? So I thought we'll talk about case studies from that point of view, rather than kind of me just didactically telling you about things. And this is a 59-year-old man with a 3-month history of weakness of the left hand and occasional tripping and no numbness. So it's mainly weakness of the hand. So it's a kind of subacute to more chronic onset, but maybe a little bit faster than you'd like. And occasional tripping suggests that maybe it's more than just the hand affected, but definitely there is some abnormality in the hand. And you can see the picture of the hand here. And you can see that there is definitely asymmetry, isn't there, between the two hands. I don't know if anybody wants to hazard a guess of what you might be worried about in this particular scenario. What kinds of things might worry you about these hands? Very easy when you're on a purely virtual forum. Well, I'll keep going. So the things to me, the red flags in this kind of scenario is the asymmetrical weakness. So he doesn't have generally cachectic hands. They don't both look like he's generally not been eating as much as he should, and fairly symmetrical. It's quite asymmetrical. It's very restricted to this left hand here. There's very significant wasting. You can see the difference between the muscle size on both sides, and that's very worrying in itself. And things haven't happened suddenly and then started to get better. He's continued to get worse, and there's no numbness, so it's all pure motor, and all those things will make you worry. And then you'd ask them about sensory symptoms. You'd examine them to look for any sensory symptoms anywhere. You'd ask him about his breathing and his swallowing, and you'd ask him about what exactly is going on with the tripping. Is there weakness in the foot when you examine him?
No, Captain, join. I can't, they don't know.
Sorry.
Bit for research, I think.
All right, so what are the differentials in this kind of scenario? Well, I guess my top differential for something like this with that asymmetrical wasted hand would be something like motor neurone disease. That would be my biggest worry. But it could be something like a cervical cord lesion or very severe radiculopathy to get that level of wasting, and that looks like it's doing more than one route. So I don't think a radiculopathy would be enough to explain this. But motor neuron disease would be my top differential. And the other one, and I have seen a patient with exactly this history who actually had something called multifocal motor neuropathy, which is actually an inflammation of the motor nerves. And so it wasn't motor neuron disease. And this is a very treatable condition, which gets drastically better when you give them IVIG, to the point of you can reverse a lot of their weakness if you get in early enough. And then I guess the other big area I would worry about is something like a brachial plexopathy. If the onset was sudden onset and fixed and not progressive, you think about things like strokes, and you would also think about maybe a tumor in the brain or inflammatory lesion in the brain to give this. But this slowly progressive nature would make a stroke and demyelination very unlikely. So I thought I'd just talk very briefly about motor neuron disease, and that's obviously what that patient had. So motor neuron disease is essentially death and degeneration of the motor neurons. There's anterior horn cells sat in your spinal cord going out into your muscle. And the classical presentation is a mixed upper and lower motor neuron signs. So what do I mean by that? Well, they have that combination of brisk reflexes, but they look like they've got lower motor neuron problems. They have wasting and they have atrophy, which you tend not to get until very, very late in central syndromes. They have weakness and they will get marked fasciculations. Now, unfortunately, the HCA computer won't let me play this video, which shows active fasciculations, but you can see the atrophy in this tongue here. And you can imagine that the tongue would be twitching. They can get dysarthria, they can get dysphagia, so it's really important to ask them about swallowing difficulties. And they can get type 2 respiratory failure. And I guess the key thing I tend to ask them about is whether they have any breathing difficulties when they lie flat, because that often indicates diaphragmatic involvement. So you'd ask them about that. You'd ask them how many pillows they sleep at night, can give you a pretty good indication. Now, we've also discovered more recently that can be associated with frontotemporal dementia. So there's a specific gene associated with that. And so patients often, they say that, somebody has motor neuron disease because they're far too nice. And actually that's the frontotemporal side of things. So they get disproportionate frontal lobe atrophy, and can often lead to a very, very positive demeanor. And sometimes they won't be affected by the fact that they have this very severely wasted hand. And they'll say, oh, it's not a big deal, when actually you think most people would be very worried about it. So what do you need to do for a diagnosis? Well, I will usually always do an MRI brain and spine to make sure there's no other cause, because you don't want to be diagnosing this without being 100% sure. And then the next question will be to do a nerve conduction study in EMG. So you're looking at multiple different sites. Usually what they'll do is they'll look at the tongue, they'll look at your paraspinals, they'll look at cranially innervated muscles, and then they'll look at arms and legs and look for denervation in all the different points. And to have a positive nerve conduction study in EMG for motor neuron disease, you have to see it in multiple different areas, a combination of this acute and chronic denervation. They may have lots of fasciculations everywhere, but often that's a very late sign. So often part of it will be normal. And sometimes I'll have to do serial nerve conduction studies or EMG to show that somebody has motor neuron disease, because the first one may not pick it up. And what's the management? Well, the only licensed management at the moment is Riluzole, which probably buys you an extra 3 months. So it doesn't give you very much. Actually, the single most useful thing is to be followed up by someone with a specialty in motor neuron disease, or to be at a motor neuron disease centre where you have access to all the supportive treatment, because that's what makes a difference. So non-invasive ventilation. I often will talk to patients very early on, well before they have any swallowing difficulties, about a PEG or some form of external nutrition, because actually what prolongs life better than anything else is to have good feeding and to maintain weight, because once you start losing weight, you're losing muscle, and so the outcome is much poorer. So maintaining their weight early on, well before they start to have any significant swallowing difficulties, is important. Now, the average prognosis in motor neuron disease is around 3 to 5 years from diagnosis. That does depend on what type of motor neuron disease you have, but in the typical form, that will usually be the case. So I'm going to go on to proximal weakness. Does anybody have any questions about motor neuron disease or any of that before I move on? I'll keep on going. So if a patient presents with proximal weakness, that's a very different picture from that focal unilateral weakness that we saw there. So this is case study number 2. So this is a 64-year-old lady who had a 2-month history of walking difficulties, a 1-month history of difficulty lifting her arms, and a 5-kilo weight loss history. And you can see her appearance. So you can see the rash on her eyes, and across her knuckles, and maybe in the nail folds, you can also see a little bit of change there. And so the first thing I always think about is, what is the pattern of weakness? Is it proximal, symmetrical? Is it gradual onset? What exactly is the pattern that you're dealing with? And when we see that pattern, that mix of proximal, symmetrical, gradual onset, myopathy becomes top of my list. When you don't have any sensory symptoms, and you have this kind of more slow onset. So what are the red flags in this particular scenario? Well, the weight loss is obviously a big red flag. 5 kilos of unintentional weight loss is a lot of weight to lose. The rapid progression, so I know it's not rapid by probably what you would see normally day to day, but for a neurologist, a 3-month history of progressive weakness is very rapid for me. And the rash is the other big red flag in this particular scenario. And so what you're going to ask about, well, the history of the rash, is this something she's always had or knew and followed the history of her weakness? If there's any history of cancer, and that's why the weight loss also becomes a big problem. And then exposure to medications. So is she on any statins? Is she on anything that could be worsening her, triggering her weakness? And so in this scenario, so obviously your top differential in her will be something called dermatomyositis, which is an inflammatory condition of the muscle. And in a large proportion of cases, especially in this kind of age group, they're driven by an underlying cancer. So we'd look very hard for cancer as the driving source, because it doesn't matter what you do immunosuppression-wise. If you don't find the underlying cancer that's causing it when it's cancer related, then they'll continue to get worse even with treatment, or they'll recur very quickly. There's also this group of immune-mediated necrotizing myopathies, which are often statin-induced, and I guess that's probably the biggest worry from general practice point of view is when you're putting patients on statin, a large number of them might get a little bit of myalgia, and actually that won't cause this kind of scenario, but there's a very small proportion that may end up with an immune-mediated necrotizing myopathy. And in those patients, you have to stop the statin, but often because it's necrotizing, you're actually damaging the muscle, you will have to start them on fairly aggressive immunosuppression early on. And there's this rare condition called infusion body myositis, which looks a lot like dermatomyositis. They tend not to have the rash, but they are much more slow, indolent progression of proximal weakness. And then inherited myopathies is the other big group that I'll see where they get very, very slow progression. So over 5, 10, 15, 20 years, they get slowly weaker and weaker, and that tends to be the tempo of those patients. So she had a dermatomyositis. And so what things are we looking for when we worry about a myopathy? Well, we're looking for difficulty rising from a chair, raising their arms up, climbing stairs. So often their primary symptom will be around climbing stairs to start with, and then might start to get difficulty rising from a chair later on. And they may well complain of fatigue and exercise intolerance as their first symptoms, because though they don't realize that they're getting weaker, actually that's exercise, and towards the end of the day, that's when they're going to notice the weakness more than any other time. When you examine them, they'll get this symmetrical proximal weakness, and you may see the wasting, especially in their quadriceps muscles. And you might notice some ptosis or facial weakness if it's an inherited form of myopathy. They should have normal reflexes. So unless they're profoundly weak, their reflexes should be normal, and there shouldn't be any sensory loss if it's going to be a myopathy. And so what are my red flag symptoms? What's going to make you refer a myopathy in very quickly? In other words, what things are not going to point you towards an inherited cause? Well, if it's rapidly progressive in weeks to months, then that would be very unusual, and you'd be worried about some kind of inflammation. If they're having significant swallowing difficulties, again, that's going to make me want to refer them earlier rather than later. If there's any breathing difficulties, because with swallowing and breathing difficulties, those are the ones who may end up suddenly needing some form of ventilation. And so those ones you're going to refer much earlier than anyone else. If they have a rash, again, that's going to point you towards an inflammatory dermatomyositis. And if the CK is very high, that's going to make you worried about maybe a rhabdomyolysis or something like that. Now, of course, inherited myopathies can have a high CK. So if it's a rapid history with a very high CK, you're going to refer very urgently. If it's a CK that's been high for a while and actually very slowly progressive, you're going to be slightly less worried about that raised CK. And then the commonest cause of myopathy, well, we talked about statins. Steroid long-term prednisolone use can cause a slowly indolent myopathy, and that's probably, you'll see that far more than I will see it in clinic. And then inflammatory dermatomyositis, as we said, that lady had. And then endocrine causes, so thyroid, hypothyroidism, if it's left untreated, can give you proximal weakness that usually recovers when you treat them. Cushing's, again, just like steroids, can give you a slow onset proximal myopathy. These tend to be rare causes, and we tend not to see it because usually they're far more symptoms well before they get to the stage of having muscle weakness. And then genetic causes, so something called fascioscapular humeral dystrophy, where they get facial weakness and limb weakness. So what should you do? Well, you can do blood tests. CK is a very good place to start if they have bilateral weakness and it looks like it's slowly progressive, because that gives you an idea as to whether you should be worried and sending them in. And then tumor markers if you think they could have dermatomyositis. Respiratory function. So when I say respiratory function, even just a peak flow to start with, to just know what you're starting with is worthwhile. But actually, the other thing that you're going to worry about is what their vital capacity is. So if you have the ability to do their vital capacity in the GP surgery, that's great. But otherwise, when they get referred to us, we'll often do it for them. And then speech and language therapy, so swallowing, essentially. If they've got dysphagia, you're going to stop the statins if you're worried about myopathy, and urgent referral to neurology if there are any red flag symptoms. So what are the other causes of proximal weakness? Well, this is the other big cause I would worry about. So this is a 60-year-old female, and she presented with difficulties with speech and swallowing and proximal weakness that fluctuates during the day. So it's better in the morning, much worse in the evening. And you can see, looking at her, you can see the bilateral ptosis there. And she does look like she has a little bit of facial weakness on that. This is much easier when you actually see her in clinic. So what things are you going to ask her? Well, when are her symptoms worse? Is it better in the morning? Is it better in the evening? Is there any double vision with that ptosis that she has? Is there any difficulty with her speech? Does her speech get quieter after she's been talking for a long time? Is there any difficulty with breathing? So is she having any difficulty breathing when she climbs stairs or at night time? Is she waking up breathless at night? Is there any weakness in the arms and legs, or is it all just in her face and swallowing and breathing difficulties? Are there any fasciculations? Because of course you're going to worry about motor neuron if she has a lot of dysphagia and dysarthria. And is there any autoimmune history? Because if it's an immunologically mediated condition, she's more likely to have an autoimmune background. This is the ice pack test that she had done. So the ice pack test, if you can get hold of ice, which is never an easy thing, but if you can get hold of ice and they have ptosis, or you can get them to put ice on their lid with their eye closed for 3 minutes and then take it off and have a look, and you see this improvement in the eye opening when you do the ice pack test. I have to admit, it's probably easier to do a blood test for acetylcholine receptor antibodies than it is to get ice in the hospital. But she essentially has myasthenia gravis. So what is myasthenia? Well, that's an immune-mediated condition preventing the action of the acetylcholine receptor at the neuromuscular junction. So what do I mean by that? Well, we have your nerve, which talks to your muscle, and the way it communicates with the muscle is by releasing acetylcholine. And in myasthenia, what is happening is you have antibodies binding to this acetylcholine receptor and stopping the conversation between the nerve and the muscle. And so patients get, most importantly, fatigable weakness. They tend to get, most patients will get diplopia ptosis before they get anything else, but that's not always the case. They can get dysarthria and dysphonia, and they can get dysphagia. And actually, if they have any bulbar symptoms, so difficulty with speaking, difficulty with swallowing, difficulty with breathing, those are red flag signs for me. They tend to get fatigable proximal weakness, and much worse towards the end of the day, or if they've been exercising or doing things. And they can get quite profound neck weakness. And so these are the patients that can present with head drop. So it's an important differential to think about when a patient complains of their head dropping and respiratory and diaphragm weakness, as we talked about. So what would you do for her? Well, acetylcholine receptor antibodies in the blood test is a good way of working out. Now, when you are in the private sector, that can be done very quickly. On the NHS side, it can take over a month or so to get those back. So it ends up being a lot around the clinical diagnosis. If you suspect myasthenia gravis, then an urgent referral to neurology is really important. And then you would send to A&E if there was any breathing or swallowing difficulties, because those are the patients that can suddenly become very unwell. So they can suddenly have a myasthenic crisis if there's breathing or swallowing difficulties. So those ones need to be urgently seen. If all they have is a little bit of diplopia and ptosis, then actually you can send them urgently, but not as an emergency into neurology. And so how do we manage them? So if they're pure ocular myasthenia, so it's just their eyes that are affected, actually in a lot of patients, I will try and get away with just giving them some pyridostigmine, because that can be enough. And I try and avoid immunosuppression if I don't have to. But in reality, most patients with any generalized signs of myasthenia, so in other words, if they have any arm or leg weakness, if they have any breathing difficulties, if they have any difficulties with swallowing or speaking, then you're almost certainly going to have to immunosuppress them. So usually we'll start prednisolone, and you can't stick them on a massive dose of prednisolone straight away because it can give you paradoxical worsening. So I usually start on 5 milligrams and very slowly go up. And then we'll try and early on get them on a steroid sparing agent. If they're in a crisis, and the reason you send them to A&E is because actually we could stick them on IVIG or plasma exchange very quickly and get improvement within hours. And that's the best option if they're getting worse rapidly. And if they're under 60, then we'll often look for a thymoma or even just hyperplasia of their thymus gland and do a thymectomy, because that has a much better outcome. If these things don't work, often we'll then escalate to things like rituximab. So there are a number of different options for treatment in these patients if steroids on their own isn't enough. So does anybody want to ask anything about myasthenia before I move on to numbness, which is probably something you see a lot more commonly in your clinics? So if not, I'll keep going. So patient presents with numbness. They're probably, most people that you see in your clinic probably don't have feet like this when they present with their numbness. But what are the things that we're going to want to know? Well, I guess what the pattern of numbness is the most important thing to start with. Is it just distal, bilateral, symmetrical, or is it one arm, one hand, one particular region? When did it start? So has this actually been going, in the majority of patients I see with numbness, it's been going on for 5 to 10 years by the time they see me, and actually but they've just started to notice it interfering with function or interfering with something. Is there any accompanying weakness? And most patients who have very severe numbness in their legs will start to get some weakness, though that tends to be much milder than the numbness. Are there any autonomic or cranial nerve symptoms that would worry you? And is there unsteadiness in the dark? Because actually, if you've lost your vibration sense and your posterior column function, then your steadiness in the dark will tend to be your steadiness will be much worse in the dark than it is in the light, because you're so reliant on your vision or ability to. So the first question is always, what's the pattern of numbness? So is it simple distal glove and stocking distribution that you would see in a common neuropathy, peripheral neuropathy, or is it more focal? So does it follow some dermatomal pattern where you're going to worry about your spinal cord or the nerve root being affected? Or is it in a specific nerve pattern? So is it carpal tunnel? Is it in your thumb and your forefinger? Common perineal, have they been crossing their legs over and developed a little bit of foot drop and numbness in their foot? Or on the nerve distribution, are they waking up in the middle of the night with their little finger numb and tingly? So the pattern is really important for trying to work out the underlying cause. And so case number 4 is this 54-year-old lady who I saw. So she has burning feet for the last 3 months and now feels numb up to about mid-calf. She's not weak, but she feels profoundly unsteady. And so what are the things that we need to know about her history? Well, is there any previous medical history? Does she have anything else to go along with this? For instance, diabetes? Are there any bladder or bowel symptoms? Are there any autonomic symptoms? Is there a rash? And is it rapidly progressing? If there's a rash, is there a vasculitic looking rash? Is probably the more specific question I would want to know. And if it's changing rapidly, so if things are changing, and this is neurology level rapid, so if they're changing month by month, then that is unusual and worrying. If they've been changing very slowly over 5 to 10 years, then a lot less worrying. So when I examine them, I will usually do pinprick with pin and see how high up that goes. I find that's much more accurate than doing light touch, because light touch is much harder for patients to have a definite handle on. And then Romberg, so getting them to stand with their feet slightly apart and then close their eyes to see if there's any significant impairment of their vibration sense. Are they areflexic? Because I'd expect them not to have their reflexes if they have a significant neuropathy. If they've got all their reflexes preserved, then actually a neuropathy is very unlikely. And is there any weakness? Because again, weakness, which is significant alongside a neuropathy, is a worrying feature. So in terms of when I'd suspect a neuropathy, so if they have numbness, tingling, burning, those symptoms very much in keeping with a standard peripheral neuropathy. If the weakness is distal and symmetrical, again, absolutely classic. If they have an unsteadiness, and that unsteadiness especially was worse in the dark, that suggests that their vibration sense is impaired, again, very in keeping with the neuropathy. And cramps can be very common in neuropathy. So often when your nerves are not working properly, they will go into cramp. And so whilst you might think cramps are a muscle sign, actually that they're a sign of usually the nerve not working correctly. And then when you examine them, you'll see a glove and stocking pattern of pinprick loss. And interestingly, so if you have numbness above your knee, at that point, you'd expect to start to see some numbness in your hands if this is a standard peripheral neuropathy. If they only have numbness in their feet, it would be really unusual to get numbness in your hands as well. And it's a peripheral neuropathy. I'd be much more worried about their spinal cord, their cervical cord in that instance. And then do they have much more distal than proximal weakness? Again, that would definitely point you in the direction of a peripheral neuropathy. do they have reduced reflexes, and do they have distal atrophy? And you can see the marked atrophy that these patients all have in their feet and hands. And so what are the commonest causes of neuropathy? Well, the neuropathy that you will probably see every day in your clinics will be diabetic neuropathy. And in reality, not every diabetic neuropathy needs to be referred into a neurologist, because the main treatment is going to be that we're going to tell them to get their sugars under control, because that's the best way of treating it. The other commonest cause I will see will be B12 deficiency, and they tend to have much more of a sensory ataxia picture. In other words, they're really unsteady. They're numb, but actually their biggest problem is unsteadiness rather than the actual numbness. And that would point you more towards a B12 deficiency. Then medications, that will be the other big group. So patients who have been on chemotherapy like a platin, so cisplatin, oxaliplatin, can often get very severe neuropathy in the later cycles of treatment. And that then stabilizes and then slowly improves over time. And then there are antibiotics like metronidazole, nitrofurantoin that can trigger neuropathy in specific patients. Colchicine is another one, amiodarone is another one. And then the ones that we worry about are the inflammatory neuropathies. Those are usually why patients are sent to us, because they're worried about inflammatory neuropathy. And those tend to be much patchier and much less of this kind of very symmetrical pattern of numbness and tingling, and much rarer. And then inherited neuropathies usually run dominantly in families. So there'll usually be a family history. And then the commonest is actually about 30% of patients will have an idiopathic neuropathy, which in reality is probably inherited, and we haven't found the reason, but essentially we do all the tests and everything is negative. And those, if you have an idiopathic neuropathy, that's going to progress very, very slowly and really not change very much over time. So what tests would you do on the general practice side? Well, what I would do in a young patient with signs of a neuropathy is an FBCUs and E's, LFTs, TFTs, ESR and CRP to make sure there's no inflammation, and ANA and ENA, just to make sure you're not missing a vasculitic type neuropathy. I do an HbA1c to make sure that that's not elevated, and a B12 and folate to make sure we're not missing a B12 related neuropathy. And then protein electrophoresis I tend to do in everybody to just make sure I'm not missing a myeloma or anti-MAG or basically a paraprotein related neuropathy. And then medication review to just make sure none of the medications I'm on is actually causing or worsening their neuropathy symptoms. So what are my red flag symptoms? So obviously anybody who's having a rapidly progressing neuropathy, rapidly progressing numbness, weakness in a couple of days, weeks, you're worrying about something like Guillain-Barré syndrome, GBS, and that's going to trigger you to send them to A&E straight away. But most patients are not going to present with that. They're going to, in terms of those who are rapidly progressing, I'm worried about those who are progressing weeks to months, because the commonest idiopathic or diabetic neuropathy, that's very slow, very indolent. That's going to take years to notice, whereas actually things like a vasculitis or an inflammatory neuropathy progresses much quicker. If it's asymmetrical patchy neuropathy and it's not following, it's not an obvious carpal tunnel, then that's when I'm going to worry about a vasculitis. So those ones you should be referring quickly. And then rash, again, worrying about a vasculitis. If they're very motor predominant symptoms, they have numbness, but actually their weakness is much worse than their numbness, then again, you'd be worried about some form of inflammatory or vasculitic neuropathy. And then if they have severe autonomic involvement, again, that would be very unusual for a standard neuropathy. So those are the things that would push you to refer someone rather than just treat the diabetes, for instance. So how would we expect you to manage in primary care? So what things basically can you do while you're waiting for us to see if you're going to refer to us? Well, the initial investigations, which I'm sure you will do as a matter of course, is FBCUs and E's, LFTs, TFTs, ESR, CRP, and ANA and ENA, HbA1c, your B12 and folate, your CK, and your protein electrophoresis. And I guess that's a standard broad-based screen. I would only really do a CK in patients who you're worried about myopathy. I don't think we need to be routinely doing that in everybody. And a medication review. And I guess those are the kind of basic things that just are worth thinking about doing before or whilst you're sending to us. And then in terms of what's going to make you refer urgently or the same day, well, rapidly progressive weakness within weeks. significant respiratory or bulbar symptoms, you're going to send that to A&E straight away in case they suddenly lose their respiratory or bulbar function. And if you're concerned about Guillain-Barré syndrome, so anything that makes you worry about Guillain-Barré, so rapid symptoms onset in less than 4 weeks, you're going to send them straight to A&E because they can deteriorate very quickly. And then in terms of urgent neuro, which is more of what you're going to be seeing day to day, patients who are developing progressive weakness that's not improving and impacting function should almost certainly be sent urgently to neuro. And then if they've got rash or systemic symptoms alongside their weakness and numbness, again, those are much more worrying and you want to send them in early.
Dipa, we just have a question from Shireen.
Yes.
Could you please outline what you mean by autonomic involvement in terms of signs and symptoms?
Oh, absolutely, yeah. So autonomic involvement, from my point of view, I guess the main things are going to be erectile dysfunction. So in men, are you still getting early morning erections? That's probably the best measure of male autonomic function that you're going to get. So I don't mean the kind of the standard difficulties performing and those things. It's actually the early morning erections. If they're gone, and that really makes you worry about significant autonomic dysfunction. Unfortunately, it's not so easy to ask that question in women because there's no real good equivalent. But blood pressure fluctuations would be one thing. So if they're getting a lot of postural hypotension, so every time they stand, they're dropping their blood pressure, and they've got significant neuropathy symptoms, then you'd be worrying about those ones. Heart rate variability is the other one. I mean, now all patients seem to have a smartwatch and it monitors their heart rate, and I'm sure you get a lot of people coming in saying, "Oh, my heart rate's doing all sorts of things at night." Those sort of things do make you worry about autonomic dysfunction. And then I suppose abnormal sweating is the other one that sometimes patients will come in with. Those are kind of the key things. But usually, I guess bladder dysfunction is on there on the list. So bladder irritability, but that tends to be much lower down on my list because that's a much more vague symptom. But yes, so autonomic dysfunction, usually erectile dysfunction for men, and then postural drops. So big drops in postural blood pressure would be the big one. Hopefully that answers your question. I'm going to keep going unless you tell me otherwise. So what things can you do while waiting? Well, for the patients with, I think probably the largest number of patients I see are with burning and numbness and tingling and pain in their feet. And for those ones, getting them started on amitriptyline, gabapentin or duloxetine are probably worth doing before they've even seen anyone, because it's not going to do any harm in terms of diagnostic tests. And either way, I'm probably going to start them on that if pain is a big feature when I see them in clinic. Maintaining strength. So for those who are getting progressive weakness, it's worth referring to them to physio. And usually they've all been seen by physio well before they come anywhere near me. But simple things like splints. So I had a number of patients in my NHS clinic who have had quite bad foot drop. And by the time they get to me, they still haven't had any splints or an OT review. And I know the wait is really long on the NHS side. It's much easier on the private side. So it's worth getting things like splints organised for those patients, because actually that can make a huge difference to their mobility. Just splinting the foot drop can give them much more functional mobility whilst they're waiting to be seen. And then if the CK is really high, and when I say high, I'm talking kind of in the thousands, then actually it is worth getting them to avoid repeated episodes at the gym just while they're waiting to be seen, because especially if it's a rhabdomyolysis patient, you can end up really pushing yourself into quite severe rhabdomyolysis if you exercise and your CK hasn't returned back to its normal baseline. So it's worth avoiding exercise in those patients whilst they're waiting. So I'm almost done. So my key takeaways are, when you're seeing these patients, think about, do you think it's a neuropathy? So is there distal numbness? Is there distal weakness? Are they areflexive? Or are you thinking about a myopathy, proximally weak and no sensory? And then what are your red flags? So have they rapidly progressed? Is there asymmetrical pattern of weakness or numbness? Because that would be unusual. Is there bulbar or respiratory involvement? And is there a high CK? And if you've got any of those, or if you're concerned, just please refer early. Always happy to try and squeeze patients in you're worried about into clinic. So I'm going to stop there because you've had to listen to me drone on for 45 minutes. And if you want to refer anyone or if you have any questions, these are my contact details, and always happy to answer questions about patients by email if you drop me a line. And open it to questions.
Dipa, I was just going to say, could you remind us when and where your clinics are?
Yeah, so I'm at Elstree usually on a Friday morning, and I'm at Platinum Medical Centre usually on a Thursday morning. I'm also doing some extra Saturday clinics at Elstree and Physicians Clinic. So there are other days as well. And I will, if there's an urgent patient, I will try and squeeze them in wherever. So please just drop me a line. No
Does
questions?
I don't think we have any further questions. So thank you very much, Dipa, and thank you everybody for joining online. I hope it was very beneficial for you, and we look forward to seeing you next month.
Thank you.
Thank you. Take care. Bye-bye.
Thank you.